where you live plays a significant role in how healthy you are. Given the history of racial segregation in this country and all of the policies that Dr. Moses talked about, and how racially segregated our neighborhoods are today, that is especially true when it comes to racial and ethnic minority men, as well as men in poor neighborhoods for their prostate cancer journeys. Our next session highlights the role of the neighborhood environment on prostate cancer risk. I'm honored that we have Dr. Mindy Herbert-Derouen to present on this topic. Welcome, Dr. Herbert-Derouen.
Hi, good morning.
So Dr. Herbert-Derouen is a research scientist in the Department of Epidemiology and Biostatistics in the UCSF School of Medicine. Her ongoing research efforts are focused on cancer prevention and control and address inequities in cancer outcomes due to multi-level determinants, especially structural and social determinants of health. And now, Dr. Mindy Herbert-Derouen.
Hi, thank you, Dr. Tucker-Seeley, for inviting me to speak here today with Zero Cancer. I'm thankful today for the opportunity to share with you work from my group, the Dream Lab at University of California, San Francisco, to understand neighborhoods as social determinants of prostate cancer outcomes. I'll start by providing some context for understanding neighborhoods as social determinants of cancer outcomes, and particularly how research on neighborhoods factors into our understanding of racial inequities in cancer outcomes. Then I'll review some of the research our group has done to characterize neighborhoods for research studies and to understand how they impact cancer. There is now a growing understanding of how burdens of disease can differ by place, where someone lives, works, or plays. However, efforts to prevent or reduce disease burdens still tend to focus on individuals. Our work is centered in the understanding that individuals are intimately connected to place, and that places impact their health risks through toxic exposures, behaviors, and experiences. As stated by Tanya Aguirre-Collins from the National Cancer Institute in a 2019 article, health disparities are generally embedded in social or structural determinants of health, which cannot be effectively addressed at the individual level alone. Efforts to reduce disparities and promote health equity must therefore address the dynamic interplay of multiple levels of influence to be effective. This quote relates back to a framework for understanding factors that impact cancer disparities that emphasizes how characteristics related to individuals, their immediate neighborhoods, their states and other municipalities, and the larger social and political context in which they live all come together to give rise to cancer disparities. This framework names explicitly examples at each level of influence, from social conditions and policies to individuals, genetic makeup, and biological responses. The crux of it, though, shown by this long vertical arrow, is about how these levels of influence interact with each other. What that means is that each level impacts other levels, and that this adds up to a complex interplay of factors that impact cancer inequities. Our lab focuses on work that reflects the full span of this model. Today, though, I will focus on work in prostate cancer that emphasizes the neighborhood environment and fundamental causes. I'll start with our efforts to characterize neighborhood environments. In 2015, we published an academic review summarizing research that examines specific features of built and social environments, excuse me, and presented hypotheses for how these features impact cancer outcomes across the cancer continuum, from prevention, risk, and diagnosis to treatment, survivorship, and mortality. We viewed the neighborhood built environment as features that define the physical space or physical environment, street connectivity, the food environment, population density, housing, commuting patterns, parks, traffic density, and recreation. We recognize the neighborhood social environment as several components, including the racial ethnic composition of a neighborhood, social capital among individuals who live in the neighborhood, socioeconomic status, safety, displacement and gentrification, ethnic enclaves, and segregation. This graphic puts several of our lab's prostate cancer studies in the context of the multi-level framework and shows how those studies span different levels of that framework in order to understand cancer inequities. Excuse me. A few of these studies are available for review as published articles listed here. If anyone wants a copy of any of these articles, feel free to reach out and I can share. One of these published studies is focused on characterizing neighborhoods with a large collection of measures that describe different aspects of the neighborhood built-in social environment. We used a statistical method called latent class analysis that identifies combinations of characteristics of built-in social environments and their interactions with each other to distinguish between meaningful but distinct types of neighborhoods. This table shows the different types of neighborhoods that surfaced in this process. The rows show 9 different neighborhood types, like upper middle class suburb, new urban pedestrian, or city pioneer neighborhoods. Each is named based on some of its defining features. The columns show different groups of features that define those neighborhoods. For each type, text in the cells shows the characteristics of that type of neighborhood. For example, 2 neighborhood types are the suburban pioneer and city pioneer neighborhoods. These neighborhood types are both located in cities, but not in central downtown, have racially and ethnically diverse populations, and lots of mixes of commercial and residential land use. But they are different in that suburban pioneer neighborhoods have more families and more homeowners, and city pioneer neighborhoods have more older residents, single residents, female-headed households, and renters. We characterized neighborhoods across California according to these 9 neighborhood types. Neighborhoods here are defined as census tracts, which on average have about 4,000 residents. One example of how this map extends our understanding of neighborhoods is that it's able to distinguish, for example, between 2 types of neighborhoods we refer to as Hispanic enclaves, neighborhoods with a higher proportion of residents of Hispanic ethnicity who speak Spanish as a first language. 2 types of neighborhoods with large Hispanic populations are distinguished by, among other things, being in urban and rural settings. Inner city neighborhoods in blue and rural neighborhoods we refer to as Hispanic small towns in pink. When we look closer at urban areas, we can see that within the urban space, we have characterized several types of neighborhoods, and with distance from urban centers, several types of suburban spaces. With this work, we examined survival of prostate cancer using the California Cancer Registry. For populations defined by race and ethnicity, we see differences in survival from prostate cancer across neighborhood types. But because these archetypes encompass a large collection of neighborhood characteristics, we can tease apart those specific features of neighborhoods that may impact mortality risk from prostate cancer. For example, the worst mortality outcomes were within inner city and Hispanic small town neighborhood types, which share less healthy food environments. And the only neighborhoods with higher mortality risk for Black compared to white men were predominantly white, middle, and upper class neighborhood types, which to some might seem a little paradoxical, but for us indicated that there might be aspects of structural racism in those predominantly white, middle, and upper class neighborhood types that conferred worse outcomes for African American men. And that observation leads into a study that is currently ongoing and for which I'll share some preliminary results. The RESPOND study is an integrated set of studies, 4 in total, all focused on a common theme of identifying the multi-level determinants and characteristics of aggressive prostate cancer and disparate mortality among African American men. It's the largest study of prostate cancer among African American men that's been conducted in the United States. This study works with a hypothesis that multiple social stressors at both the individual and the contextual level, including structural and social determinants of health, impact individuals' experiences of stress, and that this experience of stress is reflected in the body by processes that aggravate prostate cancer and increase a man's risk of dying from prostate cancer. 2 of the neighborhood level social stressors we are studying are structural determinants of health, contemporary redlining, and racial bias in mortgage lending. Contemporary redlining is the odds of denial of a mortgage application in a specific neighborhood, typically census tracts. Racial bias in mortgage lending is the odds of denial of a mortgage for an African American applicant compared to a white applicant in a given neighborhood. Both measures compare neighborhoods to the surrounding metro area. They're scaled indices that reflect whether a neighborhood is more or less likely than the surrounding area to experience redlining or racial bias in lending. And an important point is that these measures are adjust for or controlled for sex and loan-to-income ratio, meaning that the loan-to-income ratio, a measure of whether or not a mortgage is safe to lend, is not factoring into these biases that these measures are indicating. The RESPOND study is based across 6 states plus Detroit. These maps show how neighborhoods in these regions fit on the redlining index using data from mortgage applications around 2010. And so that focuses on a specific point that this is not historical redlining that we oftentimes see in the news. These are not HELOC maps from the 1950s or 60s or later. This is contemporary redlining. These are denial of mortgages in 2010. And the darker pink areas show neighborhoods more likely to be denied a mortgage, and those lighter areas are least likely to be denied a mortgage. This graph shows how African American and white men in the RESPOND study reside across neighborhoods defined by redlining. It shows that African American men are more likely to reside in neighborhoods where mortgages are denied. White men are more likely to reside in neighborhoods where mortgages are granted. Looking at the same distribution across regions in the RESPOND study, and just looking at areas most likely to receive a mortgage, we see that African American men are less likely to live in those areas where mortgages are granted across the regions. This difference ranges from 26% in Louisiana and Texas to 63% in Detroit. And now this graph shows how prostate cancer mortality risk differs across levels of redlining for African American and white men in 3 of the 6 regions. The vertical axis shows increased risk of mortality from bottom to top. Redlining, or denial of a mortgage, increases from left to right, indicated by the triangles. 2 main observations emerge. The first is that at equivalent levels of redlining, we see that African American men are more at risk of mortality, which shows that redlining doesn't account, doesn't account for all of the racial disparity in prostate cancer mortality. The second observation is that we detect increases in mortality with increasing denial of mortgages. This trend differs by region and by race as we look across regions, as you can see comparing California to Georgia and Louisiana. and so indicates differing impact or differing processes of structural inequities across these regions. Moving on to racial bias in mortgage lending, these maps show the second measure. Dark pink regions are more likely to have racial disparity in mortgage denial. African American men are more likely to live in areas with less racial bias in lending. Stated another way, white men are more likely to live in neighborhoods with mortgage lending bias against African American men. And this is a figure showing mortality risk analogous to that I showed you for redlining, where racial bias in lending increases from left to right. In the case of bias in mortgage lending, patterns in mortality across lending bias were generally very similar. So I'm showing results from just one region, Georgia. And what we see is that mortality does not differ across levels of racial bias. This shows that our measures are distinguishing different processes of structural inequity. They are not just reflecting that mortality risk differs across neighborhoods, but that risk differs across these measures of lending bias and structural racism. Ongoing work for this study in our lab is testing whether these measures of structural racism impact prostate cancer mortality among African American men through the neighborhood built and social environment. Work in other companion projects that are part of the RESPOND study additionally test whether social stressors are linked to prostate tumor genetics and tumor inflammation. More broadly, work in the field of place and health increasingly considers a few things: a life course perspective, that is, how neighborhoods impact health during important periods like the perinatal period, adolescence, and older adulthood. Another is resident-generated data or crowdsourced data on how people experience their neighborhoods on a daily basis using mobile applications. Another considers neighborhoods where we live with where we work. So the neighborhood where we live is very important to our health, and it is considerably more difficult to measure how the neighborhoods where we work or where we play or that we travel through affect our health. And so continuing work is looking into these areas. And finally, acknowledging and uplifting aspects of neighborhood that offer tangible benefits are important to consider, especially as we translate our research findings to interventions to improve the neighborhood environment. With all of these efforts, we remember that the goal is to understand how neighborhoods can be supported and invested in to improve health and eliminate health disparities. I want to finish up with some concluding thoughts. Equitable research of healthcare services, prevention, therapy, clinical trials, requires a multi-level approach, which is supported by the research I've shown you today. Not just outreaching to individuals, but acknowledging that individuals can be supported or constrained by their neighborhood surroundings. The second is that understanding cancer biology and how tumors grow and develop requires recognition that structural and social determinants of health not only influence our risk for cancer, but the biology of the tumors. And finally, lasting intervention to eliminate cancer disparities will address multi-level, not just individual risk factors. This last point can feel daunting because it requires structural changes, including and beyond the healthcare system. But it's not impossible, and it's important, so it's a worthy pursuit. Finally, I want to acknowledge the members of the Dream Lab at UCSF. The Dream Lab is led by faculty Scarlett Lynn Gomez, Iona Chang, and Salma Sharif Marco, with a near army of analysts, interviewers, project coordinators, project managers, and biostatisticians. And then on the right, I've listed others that have we've collaborated with for some of the studies that I showed you. And I'm happy to address any questions or to receive communication. I have my email address here and my Twitter handle.
Thank you so much, Dr. Herbert-Derouen. I do have a question. Given your results that showed different patterns in different places, does that suggest that perhaps the interventions need to be developed locally? That is, we need to understand more about those local contexts in order to think through the ways in which we intervene to address the disparities that you described.
Yes. So, the US is a huge country with a shared history, but also these regions, these states have their own individual histories as well. And I think two important things pop up. One is that the history of residential segregation differs in different parts of the country. All parts have experienced racial segregation and still do, but the processes by which racial segregation was executed may have occurred differently in different areas with different results. So I'm recalling a passage from Doug Macy's book on American apartheid, that the spatial distribution of segregation in the South differs from other areas of the US based on the history of slavery in the South compared to other parts of the US. And even though what we're measuring here is contemporary redlining, I think it's important to note that contemporary redlining is a legacy of historical redlining. And even though it's happening differently, the results in the neighborhoods are a little bit are not the same across the country. And I think that leads into exactly what you suggested, that there may be federal policies, there may be that can address some of the policies that perpetuate structural racism and segregation, but that also there needs to be work at the regional and local level, because there will be differences between these regions. Absolutely.
Yes. Yeah. So we have to do that thing, which oftentimes is really hard for us, which is two things at once and thinking at multiple levels. So we have to think about, the federal level sort of policies that we need to address, but also how those policies were actually implemented at the local level may look different, which then suggests that the intervention at the local level may look different if you're doing it in one region versus another. Great. Well, Dr. Herbert-Derouen, thank you so much for this presentation. When I saw your paper on the neighborhood environment and risk for prostate cancer, I knew I had to reach out to you and Dr. Gomez. So thank you both. Thank you so much for presenting. Thank Dr. Gomez and all the work that you all are doing in the Dream Lab. And we look forward to staying connected here at ZERO.
Thank you for having me.
Thank you.